And now it's definitely my pleasure to announce the last keynote lunch lecture of this course, which will be given by Professor Johan Van Goethem on a very interesting and difficult subject on spondyloarthropathies. Johan, stage is all yours, and we are now broadcasting live.
Good afternoon again, everybody. So after the workshops, we will have this lecture on spondyloarthropathy, and I will mainly focus on making the differential with degenerative disease. We will look at the different features of spondyloarthropathy, but I think many of you know, but the important thing is that you as a radiologist sometimes will be the first clinician, first medical person to make a diagnosis or suggest a diagnosis of spondyloarthropathy in a patient. I will follow your presentation that you have online, but I have added a few examples which you don't have, don't worry. So if you get an image like this on an elderly patient with low back pain, it should be not too difficult for you to pick up the abnormalities here. We can all see that except for the fact that there's of course multi-segment degenerative disease, even with modic type 1 changes. This patient also has alterations at the thoracolumbar junction with lipomatous end plate changes and actually ankylosis at many levels. If you see bright signal in the disc, think about ankylosis of that segment. There's ankylosis of the lower thoracic spine with almost no osteophytic spurs. This is the typical example of an ankylosing spondylitis, and I think most of you would not miss that. This is a 25-year-old patient with low back pain, and those of you that only do T2s and T1s will get these images and will probably report it as normal. Those of you, and it has been stressed many times here, that do stir imaging, you really should do stir imaging, will get this extra image. And now it's easy to pick up these changes at the low thoracic level, corner edema at multiple levels, and this again is a hallmark of a spondyloarthropathy, and you might be the first person as a radiologist to suggest or make the diagnosis. So let's start. We'll compare these two entities, degenerative disc disease and spondyloarthropathies. We'll look into the imaging and we'll focus on the entities, the imaging differences between both, an imaging algorithm to end with a conclusion. So a definition first. There is some confusion in literature and among physicians using this terminology, but in general, abbreviated SPA with a small p and capital S and A, spondyloarthropathies are the same as seronegative spondyloarthritis. Seronegative meaning there's no rheumatoid factor. So it's a form of spondyloarthritis, infection in the spine, with negative rheumatoid factor. And that's what we're talking about. The prevalence in the spine, depending on the country where you live, is somewhere between 0.2 and 1%. On the other hand, we have the seropositive ones, which are the rheumatoid arthritis, which I will not talk about, which mainly manifests, as you know, at the craniocervical junction and C2 in the spine. Its prevalence almost the same as the seronegative ones. There are many other diseases in the spine with inflammatory changes. And some, even rheumatologists, will say that SAPHO for them is a form of spondyloarthropathy. No, most will consider this not a spondyloarthropathy, but I'll mention it anyway. SAPHO is a rare disease consisting of, as the abbreviation says, synovitis, acne, pustulosis, hyperostosis, and osteitis. And the osteitis can be in the spine. There are two forms, which is the PPHS, which is the adult form, which is also known as pustulo-psoriatic hyperostotic spondyloarthritis, but it's not psoriasis. And there's CRMO, which is usually seen in children. There's an example here. This is a typical case of CRMO. You see a child, 12 years old, with bone edema like L5S1 or L5 mainly. You might think of active degenerative disc disease, modic type 1 changes, but that's rarely uncommon in a child, although the disc has lost height and is dark. But if you look at the sacral bone, there's multi-level bone edema in a typical case of chronic recurrent multifocal osteomyelitis, which there's also an adult form known as adult CRMO. And these days, the thoughts are that both are a form of SAPHO. There prevalence in the spine of the CRMO is much lower, is around 0.04%. Then we have diseases such as the metabolic deposition diseases, which also go with inflammation, like gout, which is not so infrequent, and CPPD, which also manifests at the craniocervical junction, also sometimes known as pseudogout, with a prevalence of 0.3%. And then we have more rare things like juvenile idiopathic arthritis, Still's disease, juvenile rheumatoid arthritis, with a very low prevalence, and even things like calcific longus colli tendinitis, which we have seen previously, and things like inflammation with hemodialysis and OPLL. But we'll focus today on spondyloarthropathies, and there are 5 types of spondyloarthropathies. The most frequent one is ankylosing spondylitis or Bechterew disease. The other ones are psoriatic arthritis, enteropathic spondyloarthropathy, reactive arthritis, and all the other ones which are called undifferentiated. They have common features. The common features are chronic inflammation, and think again about the entasis. The entasis is the attachment point of the ligaments to the bone in cartilaginous joints and synovial joints. There's no rheumatoid factor in these diseases. Both the axial and the appendicular skeleton is affected, so not only the spine, and its onset is in young adults, like 25, 30 years of age. And there is a genetic predisposition for all of these 5 entities which belong to the spondyloarthropathies. On the other hand, and I said I would focus on the differential, you have degenerative disc disease, also known as spondylosis. It's a complex process, actually, that leads to disturbances in mobility, stability, and morphology, as you know, of the disc vertebral unit. In many patients, these changes are asymptomatic, but they may cause pain, and that's actually the difficulty, like seeing which are causing pain and which are not, and they may lead to significant morbidity. Lumbar back pain is still #1 all over the world in DALYs, meaning the daily disability index of all diseases comprising psychiatric diseases, cardiovascular diseases, oncologic diseases. This generation, lumbar spine, low back pain is #1. If you count the days patients suffer, and there's like a factor like how much does a patient suffer with low back pain, how much does a patient suffer with a tumor, and then the days you're actually suffering from this disease, look at it, the dailies, lumbar, low back pain is #1. The etiology of degeneration is complex. There might be a genetic predisposition. There is, of course, the mechanical loading, age and obesity of the patient, and other things like smoking, diet, local diseases, and trauma. On the other hand, spondyloarthropathy is a genetic disease. It's associated with HLA-B27, which is positive in 95% of the patients with ankylosing spondylitis and 80% positive in the patients with Reiter disease. This factor is found also in about 6 to 8% of the normal population. And some people will say there might also be an infectious agent. In degenerative disc disease, the clinical findings are back pain or neck pain and irradiating leg pain or arm pain. In spondyloarthropathy, it's the same. There's also back pain and neck pain. Not as much irradiating pain, but stiffness of the spine. There can be pathologic fractures, especially when there's ankylosis, of course. And this patient, because they have a chronic inflammation, will show fatigue and fever. The treatment of degenerative disc disease is not well defined, but most will either start with rest or start with exercise or both, changes in lifestyle, losing weight, doing sports, drugs, anti-inflammatory drugs, either oral or locally, and sometimes even surgery. The important thing here is that the treatment in spondyloarthropathy is different, and if you're the one that makes the diagnosis, that's very important for the patient. There are specific drugs that are available for these patients, and also exercise is usually prescribed. So put it in the table, the degenerative disc disease in the middle, the SPA at the right. The symptoms are different. It's inflammatory in SPA, it's mainly in the morning. It's mechanical low back pain in degenerative disc disease. Mechanical means it gets worse after using your spine, so it's worse in the evening. SPA is worse in the morning. Onset is different. Degenerative disc disease is usually after 45. SPA is like between 20 and 30 up to 40. The gender in degeneration is about the same between males and females. In the SPAs, it's more males. And there are other things like blood tests, CRPs, inflammation, ESR, looking at genetic factors in SPA. And the imaging is different, and we'll focus on the imaging a little bit later. So we'll mainly look at the enthesis. Again, the enthesis is the attachment of ligaments to the bone. In the spine, the main attachment to bone at the vertebral body is anteriorly by the ALL. The PLL is only loosely connected to the bone and loosely connected to the annulus fibrosus, and that's one of the reasons why most disc herniations are posterior and are not anterior. It is attached on the mid-sagittal line, but not parasagittal. That's also why most disc herniations are parasagittal and not on the midline. But so the most important enthesis is anterior in the spine. What are the radiographic hallmarks of degenerative disc disease? It's height loss of the disc, stretching of the annulus, because if you lose height, the annulus will be stretched due to the bulging of the disc outward, and corner lesions. And you have osteophytes, which we call spondyloarthropathies, which will form at the attachment of the ALL. And that's important to make the differential, and I'll show it the images. In spondyloarthropathies, we have inflammation, which means you get erosions of the bone, repair, which leads to sclerosis, so you have erosions and sclerosis, and that might lead finally to ossification and ankylosis. Of course, a hallmark is bilateral sacroiliitis, and they also have vertebral corner lesions, which are known on plain X-ray as Romanus lesions, and there are osteophytes, which we know as syndesmophytes, and they are different because they form at the outer annulus, and spondylophytes form at the insertion of the ALL. In degenerative disc disease, there's rupture and stretching of the sharpest fibers being the outer fibers of the annulus fibrosus. So what happens is you lose height of the disc, and then you get stretching of the outer annulus fibers and traction on the ALL. Now, the ALL attaches not at the corner of the vertebral body, but just below the corner, actually, and that's where the osteophytic spurs will be seen. Imaging correlation on X-rays and CTs, and if you go back next week and look at CTs of degenerative spines, you will see that often there's a small vacuum phenomena just at this point of the disc. On MRI, we see high signal due to inflammation. So go back to your packs and look next week. You often see these small vacuum phenomena dots exactly at this location, and these are a sign of degenerative disc disease. Also look at the fact that it's spondylophytes not form at the corner, but just below the corner of the vertebral body. And it will be more obvious in other cases. And there might be accompanying edema. Not all edema in vertebral corners is due to spondyloarthropathies. It might be also due to degenerative disc disease. It leads to microinstability, and the microinstability leads to formation of the spurs, stretching of the annulus, and all of the changes we see in degenerative disc disease. And again, these are called spondylophytes. And again, these are formed just a few millimeters away from the true edge of the vertebral body, and that's a sign of degenerative disc disease. It's the attachment point of the ALL. It finally also leads to new bone formation and sclerosis, which can be seen both in degenerative disc disease and spondyloarthropathy. And then you get these large osteophytic spurs, again, a little bit away from the corner. They tend to grow larger, and in some patients, these will fuse, and you get these large fused spondylophytic spurs, and you get ankylosis, which is also possible in degenerative disc disease. On the other hand, we have the spondyloarthropathy, and the underlying pathologic process is different. It's inflammation at the insertion, so enthesopathy, at the outer layers of the annulus fibrosus. So it's a little bit more inward, and this inflammation extends all the way under the ALL in front of the vertebral body, which leads to bone formation and squaring of the vertebral bodies, which is a sign of spondyloarthropathy. You also get this corner lesion, which we know on plain film as Romanus lesion, and the signal intensity on MR, edema, sclerosis, or edema, fat sclerosis, correlates to the stage of the disease. How does it look like? It looks the same. It's bone edema at the corner, but the difference here is that this disc is completely normal. So in degenerative disc disease, the first thing that happens is loss of water, loss of signal, loss of elasticity, and then loss of height, and then traction, and then edema. So if you see a normal disc, this is probably due to a spondyloarthropathy and not to degenerative disc disease. Again, you can see it at multiple levels, especially at the thoracic spine, which is much more rare in degenerative disc disease. And this multi-level edema at the anterior vertebral corners should surely make you think about a spondyloarthropathy, especially when the disc looks quite normal or is only a little bit degenerative. Again, there's extension under the ALL in front of the vertebral bodies, leading to squaring of the vertebral bodies, as is clearly seen on this image. A square vertebral body is a clear sign of a spondyloarthropathy, and you look at these lesions, these sclerotic regions, which are a later stage, which we know as these Romanes lesions. And then you get formations of syndesmophytes. Now, syndesmophytes are these things. If you see these small bony spurs at the corner of the vertebral body that form vertically and sometimes already fused to vertebral bodies, this is very typical of a spondyloarthropathy, usually an ankylosing spondylitis, finally leading to squared vertebral bodies and a fused spine, which we will call a bamboo spine because it resembles a bamboo. What about the other ones? Do they look different? Not especially. It will be very difficult to make a differential on imaging. A few things in psoriatic. You have this voluminous, non-marginal syndesmophytes, so they are called parasyndesmophytes, a little bit to the side, as in this example, and they usually give ankylosis quite soon. And in psoriatic, contrary to the ankylosing spondylitis, the sacroiliitis tends to be asymmetrical. That's another case of psoriatic. In ankylosing spondylitis, you could see the same thing, but cervical spine is not a predilection for AS. The predilection is thoracic and thoracolumbar. These are two cases of psoriatic spondyloarthropathy. In enteropathic, which goes along with Crohn's disease or ulcerative colitis, the changes are as in ankylosing spondylitis, but the inflammation tends to be very pronounced in the posterior elements. I think this is a very unique image with extensive edema in the spinous processes and the soft tissues in the case of enteropathic spondyloarthropathy. So, think of degeneration when you see tears in the anterior anafibrosis, the anterior vacuum phenomenon, that small dot just at the corner, traction osteophytes which form away from the vertebral corner known as spondylophytes, corner lesions at the mid-lumbar level, typically L3, L4, and isolation to one vertebral body or one vertebral corner. So again, even the vacuum phenomenon can be seen on plain X-ray as here. It's more obvious on CT, and these osteophytic spurs are away from the vertebral corner, and there's only edema at one level, at this case L4, so this is typically degenerative. Think of spondyloarthropathy if there's inflammatory type of back pain, involvement of more than 2 or more levels, which has a fairly high specificity, extension of the inflammation under the ALL in front of the vertebral body, corner lesions at the thoracolumbar junction, and formation of syndesmophytes and ankylosis. Also look at other parts. Of course, the sacroiliac joints are very important. We come back to that in a few minutes. But also, for example, at the heel and in the spine, an extension in front of the vertebral body, which is fairly atypical in degenerative disease. And again, these discs are normal. This is almost surely an ankylosing spondylitis. So for the diagnostic approach to these patients, it's still based on the clinical diagnosis. It's the gold standard. But imaging may confirm the diagnosis, so many of your rheumatologists will ask or order imaging, which will be imaging of the sacroiliac joints. If the sacroiliac joints show sacroiliitis and there's one SPA feature, the diagnosis is made, or when you have a patient with HLA-B27 positive and 2 features, also the diagnosis is made. These features are inflammatory back pain, arthritis, enthesitis, especially at the heel, uveitis, dactylitis, and psoriasis. So if 1 or 2 of these are present, together with imaging positive and or HLA-B27 positive, the diagnosis of spondyloarthropathy is made. Clinical suspicion is raised by chronic back pain, especially in young patients, inflammatory pain, so more in the morning, less in the evening, start at a young age, HLA-B27 positive and positive inflammatory parameters. CRP is positive in more than half of these patients. If these are positive, then more than 50% of these patients will turn out to have SPA. In imaging, we look at radiographic sacroiliitis, so on plain films, it's seen like in 50% of patients. If not, you can go to MR, and we call that MR active sacroiliitis, where we look at bone edema. Bone edema, and I come down to my favorite sequence, is seen on stir imaging. You might think stir imaging and showing bone edema is very specific for sacroiliitis and spondyloarthropathy, but unfortunately it's not. People will say, yeah, it will help you make an early diagnosis, which is true, but don't forget the bone edema goes away and disappears quite quickly in many patients. They will say it's sensitive, but on the other hand, it's not specific. Bone edema in sacroiliac joints are also seen in degenerative sacroiliac joints or in trauma. And the sensitivity actually is not as high as we might wonder. It's only like 60 to 70%. Which is very specific, on the other hand, are erosive lesions at the sacroiliac joints, which we can see on plain film, CT, MR. So look at this T1 weighted image. You see the erosions of the bone with sclerosis, which is very typical for a spondyloarthropathy. It's even easier, of course, to look at these on bone CT. But these days, what we use on all these patients is called bone MRI. So this image, the right lower hand image, is MR. It's not CT. There's no radiation. There's no nothing. It's just another sequence you perform. And you get these images. And this is the same patient. That's CT. That's MR. And actually, this is very useful looking at erosive lesions of the sacroiliac joint, which again are very specific for a spondyloarthropathy. On the other hand, we can also use CT to look at bone edema, which is also a sign of sacroiliitis. So this is a patient with bone edema. We do dual energy CT, which shows you these edematous changes in the subcortical bone at the same location. So CT shows you edema and MR might show you erosions. Probably you will prefer MR and the patient will prefer MR because there's no radiation. So I come to a conclusion. First of all, SPA, spondyloarthropathy, and seronegative spondyloarthritis is the same. It's a rare disease, but it's important that the correct diagnosis is made because there's a different course for the patients and there's a different treatment. It's a complex group of diseases with some of the features the same, and ankylosing spondylitis is the most common one. There are distinct but sometimes very subtle changes in imaging. Look at the enthesis, the attachment of the ligaments, the location of the lesion, the age of the patient and symptom of the patient, and for imaging, use both plain film and MR. Thank you very much for your attention.